Okay, so yes, Dr. Hruschka, if you want to start by introducing yourself.
Certainly. Well, Cheyenne, thank you so much for inviting me to speak with all of you today. Um, my name is Dan Hruschka. I wear two academic hats. I'm a anthropologist, a medical anthropologist, but I'm also an epidemiologist. So I work both in the fields of global health and in anthropology, and I'm excited to share with you a little bit about what we do. Um, I think maybe we'll just get started with the presentation. Does that sound good? All right. Um, okay, can everyone see the presentation? Okay. When Cheyenne invited me, she asked if I would just give a little introduction to like what medical anthropology is. And I thought the best way to do that was kind of describe to you um, how I became a medical anthropologist and one of the studies I've been involved with recently, and then maybe describe what some other medical anthropologists do. But before we start, I wanted to ask all of you, when you hear the word medical anthropology, what do you think it is? Would anyone like to share their perspective on what medical anthropology is? Cheyenne.
To me, when I explain it to people, one, because a lot of people don't really know anthropology in general, but I always say it's kind of picking up where doctors leave off because we're not doing on medicine, but we're just kind of filling in the gaps to like really listen to people, like from their get the patient's perspective on things and help them in that way. And then also
So
like
really trying to get the patient's perspective, right? And then what was the second thing you were going to say, Cheyenne?
oh, I was just saying like filling in gaps. Like when I was talking to some kids about medical anthropology, I was kind of just explaining to them that you're seeing how disease can arise from things people might not think about, like social factors and environmental factors, things like that.
That's great. I think you hit it on the head. So I always think of medical anthropology as it's one branch of anthropology. Anthropology wants to understand the diverse ways that people think and behave and live and make societies around the world. And medical anthropology focuses specifically on how they heal, who gets sick, why they get sick, what are the causes of that. And like you said, Cheyenne, oftentimes the causes are social and cultural. And that's one thing that we're really interested in. And so, like I said, I'm going to first of all just talk a little bit about myself in terms of how I got to where I am now. Some of my research in Bangladesh. I've been working in Bangladesh for the last 15 years now, I think. And I've been able to go back at least once a year, except during COVID. I had a plane flight in March 2020 that they canceled as I was about to get on it in a few days. But other than that, I've been going back for the last 15 years. And then I thought I would share with you what some other medical anthropologists do, because there's diversity in what medical anthropologists are engaged in. So a little bit about myself. Um, I started off I grew up in a small town in Ohio. I was very interested in mathematics. I found mathematics the most interesting subject in the world. I thought it was giving answers to the universe. I love the way that you could use proofs and theorems to actually arrive at truth. And I took that love of math to undergrad. Well, my second year in undergrad, I got diagnosed with cancer. And so I had to start getting chemotherapy. And I went to the hospital on a regular basis, and I hung out with other folks getting chemotherapy and realized that there were a lot of people dealing with suffering and coping with it in ways that mathematics could not really answer or address. And so I got very interested in how people deal with disease, how they stay healthy. And I was naturally interested in how this happens around the world. So how do people in different parts of the world do this? So I stayed with math, but I got very interested in learning more about other cultures and how they approach healing, how they approach disease. And I only really found medical anthropology after I graduated from college and went to work in Mongolia for a year. And I met some anthropologists there. And as I started talking to them, I was like, you're doing what I want to do. So I applied to a few programs after 2 years. I spent a second year in Mongolia teaching English. And then I was lucky enough to get accepted to a medical anthropology program. And kind of that's history, right? So that's how I got to where I'm at. I still use a lot of mathematics in my work, which is kind of strange for a medical anthropologist, but I also love the learning about people aspect of it, where you interview and observe and get to interact with people from other cultures. So for the last 15 years, I really focused my work on some communities in Bangladesh. Bangladesh is a fascinating place. There are 170 million people. It's about half the size of the United States, crammed into an area the size of Louisiana. So imagine taking half of the United States and then putting them all in Louisiana on a floodplain where there's oftentimes frequent flooding in a floodplain. So there's people everywhere. The population density is 30 times what it is in the United States. The vast majority of folks living in Bangladesh identify as Bangla as their ethnicity, but there are other groups too, Santal, Mandi, Garo, Hajong. And so there, even though the majority are Bangla, there is some ethnic diversity. Most folks identify it as following Islam, but a smaller proportion identify as Hindu, and then there are some Christians and Buddhists as well. And as you can see from this picture, this is a scene you'll see in all parts of Bangladesh is rice paddies. So across this floodplain, you find at any given time rice paddies growing, people harvesting them. This is life in this is actually key to life in Bangladesh. This is what sustains life. The work I do is not alone. I work with groups all the time. I work with sometimes large groups of 20 people, sometimes groups of 5 people. And in the last 10 years, I've really concentrated work with a hospital called Lamb Hospital that works in Northwest Bangladesh, which is both a hospital, but it also provides maternal and infant care, like prenatal care, in an area of probably about 1 million families in the area around the hospital. So they both do community development and also they provide hospital services. And I work with local organizations to identify social determinants of health and disease, and also try to identify opportunities to improve health. And I'm going to describe one case study from about 7 to 12 years ago that we started working on. Oh, hello? Hi, welcome. It was a study on what we learned from we were doing a study in 3 sites about how birth complications are identified. So how do women and their caregivers identify there's a problem or complication, and how do they go about treating that or seeking help for it? And as part of that, a lot of women and caregivers talked about using injections to increase labor pains. That was the term they used in home settings. And these were confirmed in both open-ended interviews and surveys. Now, this is the colloquial term for it, but what we learned through some more interviews was that this really meant using a drug called syntocinon, which who's heard of Pitocin before, or oxytocin? Yeah, I see a few hands being raised. Syntocinon is a really powerful and useful drug. It can be used, oftentimes used in the United States to induce labor, so it strengthens uterine contractions. But in those cases, it's recommended to be used in very specific situations, like making sure it's an intravenous infusion, that there's continuous monitoring of the fetal heart rate, contraction, monitoring of contraction duration and strength, and adequate medical supervision. Because if, for example, the baby's not ready to come out, if maybe the mother's not dilated enough, administering this can actually be very bad for the baby and the mother, because the baby is trying to come out, but actually there's no space to come out necessarily. The other way it's been used is in active management of 3rd stage labor. So after delivery, it can be used to promote uterine contraction, so to prevent postpartum hemorrhage, which is one of the leading causes of maternal mortality worldwide. So syntocinon has been made widely available in places like Bangladesh, and you can get it without a prescription because of this life-saving aspect of it after delivery. The issue is that if it's used in a situation where, for example, you can't monitor the fetal heart rate, You can't actually determine whether the mother is ready to deliver, whether she's appropriately dilated. It can lead to lots of problems. So it's powerful in terms of being life-saving, but it can also actually cause a lot of problems. So some of the adverse consequences are things like uterine rupture, or bleeding or shock for the mother, or stillbirth for the infant, or birth asphyxia, or developmental delay. And so what we found through some additional investigation using interviews, participant observation, surveys, is that Syntocinon is widely available without a prescription at village pharmacy shops. And a pharmacy shop is oftentimes just a table with maybe a set of boxes like this with different types of medicines in it. So you might have deworming medicine, you might have aspirin, and then you can have vials of Syntocinon. And so when someone's giving a birth in the home, caregivers could just go to this, they're called village doctors, and get vials of Syntocinon and inject them. And one thing we learned too is they were not being injected intravenously. They were being injected just kind of in the muscles, which means you don't have as much control as to the potency of it. And also you don't know the potency of the drug because it hasn't followed a cold chain. So it hasn't necessarily been refrigerated the whole way. So for those reasons, sometimes you'd find that women had been administered like 7 vials because the first one didn't work and the second one didn't work. And by that time, they're in a pretty bad state because of the uterine contractions that are being caused by that. So we did a few things. We had some questions. One was, well, what are the health effects of this on mothers and infants? And then how are they being used? And what can we do to try to prevent any kind of infant deaths that might be caused by this? So LAM has a unit, which is a research unit, and they actually added a question to both the hospital birth registers, so when people came in for deliveries, and also in community surveys that they do about, did you have injections to increase labor pains before going to the clinic? And we learned a lot just from that question. First of all, we were able to link that up with health outcomes that were collected by the hospital and also the community at the community level. And what we found and estimated was that about 10% of early neonatal deaths in that area could be attributed to the use of Syntocinon in these home birth settings. That's 1 out of 10 of these early neonatal deaths. 16%, so 1 out of 6 fresh stillbirths were likely attributed to the use of Syntocinon in these home-based settings without supervision. And so we decided this is actually a problem we need to try to work on, right? So we also were able to map key areas where people reported much higher levels of Syntocinon. So there's Lamb Hospital right there, but then there's different regions around it. And you can see the areas in red are places where 1 out of 6 women were using Syntocinon in home birth settings to induce labor. And so that helped identify places to focus educational efforts. And this is just showing that we also found that a lot of the provision of the Syntocinon was coming from village doctors. Now, when I say a village doctor, they don't have a medical degree. They are someone who might have a little training, maybe like 6 weeks of training, and then they oftentimes will provide prescription drugs in areas, although they're not really prescription because people don't get them as prescriptions, they can just get them. And so a large part of them were being provided by these village doctors. So what I'm going to talk about now, I played some role in, but this was really the Lamb staff, the Lamb Hospital staff were really the ones who initiated these efforts to do an intervention to try to prevent the use of Syntocinon in these home birth settings. One was they had developed something called a pictorial partograph, which was a locally appropriate way. Now, it wasn't in English, it was in Bangla, but here it's in English so you can read it. But different aspects of the delivery process that people should pay attention to, and then some recommendations about things that they should be doing or not be doing. And in that, they actually had an icon that's the one circled in a blue circle that indicates you shouldn't be taking injections to induce labor in home birth setting. And that would be explained to the women, and also the caregivers and community health workers understood what that meant. So that was in the pictorial partographs. And then they also developed a number of local kind of theatrical musical performance type things to communicate a lot of these things by using storytelling, right? And so this is one example of that kind of event where you get their attention, and then you can communicate important details of problems that can arise during delivery, and then things to avoid if so that things go well. And then what we found from that was that after this intervention, there was a big reduction in both stated approval of these injections in the home birth setting, and also actually reductions in use of them. And we haven't yet looked at the change in infant mortality, but that's kind of the next step, is to see what has been the improvement in infant mortality. So the conclusions there are inappropriate use of Syntocinon, which is a powerful and life-saving drug in some contexts, but in other contexts it's not. It's really got to be used in the right way. It can double or triple the risk of mortality. 10% of perinatal deaths and 16% of fresh stillbirths likely were caused by it. There was wide variability in use, largely due to some doctors, village doctors were more likely to give it than others, but it was possible to reduce rates by using different communication strategies in the local communities. So that's one project that I was really excited to be part of, and happy that they let me play a role in that. And like I said, it's in a team. So I didn't play as much role in the intervention, but I played a lot of role in developing the interviews, developing the survey tools, and training folks on how to use those, right? And so as a medical anthropologist, that was kind of the role I played. Here are a few other medical anthropologists. Svea Klosser, she is a PhD in medical anthropology, and she's at Johns Hopkins University now. She has spent more than a decade studying polio eradication programs and the challenges to implementing them. She started working in Pakistan, where there was a big rollout of this in the 2000s, but she's also worked in India, Nepal, and Ethiopia, and her work contributes to improving coverage of polio vaccines in low resource settings, and also communicating the value of it to local communities. Another medical anthropologists combine their PhD with maybe a medical degree. So Brandon Court, he's a good friend of mine. He spent many years getting both a medical degree and a PhD in anthropology, and he studies the psychological impact of armed conflict in Nepal. And now actually he studies it all around the world. He's sought after to help with studies in Liberia and other places that have experienced armed conflict in the last 2 decades. And his expertise is in building culturally appropriate individual and community level mental health interventions that reduce stigma and improve outcomes. And he combines in-depth knowledge of local culture with, he also does psychiatric assessments and biological assessments in his work. And then Lynn Sibley, who I had the pleasure of working with in Bangladesh, she actually introduced me to Bangladesh in like 2007. She's a nurse and a PhD in anthropology. And she developed a program with others called Home-Based Life-Saving Skills, which is a participatory community-based strategy to reduce mortality, especially around the time of pregnancy and delivery. And so it increases access to basic life-saving measures within the home to reduce delays in referral if some kind of complication happens during delivery or during pregnancy. And she received the Large Gates Foundation several years ago to work on this in Ethiopia after she had first of all piloted it in Bangladesh. So that's really just a very brief introduction to medical anthropology. And I wanted to thank the folks I work with, the MISR team at LAM, and thanks to some funders that have helped fund some of this work. And also thank you for letting me share this. And I didn't want to talk too much because I want to give you all a chance to ask me questions. So I'm going to stop sharing, and maybe you can let me know if you have any questions about what I talked about.
Okay, thank you for that. I'm going to stop recording just in case anybody feels more comfortable off